All right. So the goals and objectives of tonight's talk on degenerative spinal pathology for the fourth year medical student. I do want to take a moment to introduce you all to uh, spine nomenclature. A few things that I noticed that between our junior residents and medical students get tossed out and become a little confusing with a focused anatomic review, just salient points and exam maneuvers. And then the meat of what I would like to talk about with our moderators' assistance is a case-based integration of our knowledge, 4 main cases plus a little extra at the end just to kind of round things out. And this is really meant to be a general introduction to the treatment of cervical and lumbar spine pathology. So we'll get started. So this term, this prefix, spondylo, this can be confusing unless you really have listened to it and understand what we're actually talking about here. A lot of these terms will sound very similar, and not that one is of any more importance to you as a fourth year medical student, but I think that it's important that you understand the difference between some of these. The prefix spondylo generally means we're referring to the spine. Spondylosis, you can think of that as arthrosis of the spine, as we would talk about any other synovial joint. Spondylolysis, meaning some sort of lesion disconnection of the pars intra-articularis, which is an osteologic feature of the vertebral body. Spondylodiscitis is an infection of the spine and the vertebral body and disc, generally speaking. Spondylolisthesis is a translation in the axial plane of one vertebral body with respect to another. So you can see, while these are varied definitions, they all look very similar but mean different things. And I would hope that you could kind of take this slide and kind of internalize some of these just so that you know when these terms are being thrown about that you need to be very deliberate about how you use them. All right, we'll start with the cervical spine anatomy and examination, and we'll do two cases to drive home the points. So cervical spine anatomy, we'll go through 4 points here. We'll talk about the top of the cervical spine. Generally speaking, we're referring to the articulation of the occipital condyles, or occiput with C1 and C1 with C2. Very unique anatomy here, meaning it allows the vast majority of our flexion, extension, rotation, general movement of our head with respect to our cervical spine. That increase in motion and degrees of freedom is facilitated by a very unique osteology. The C1 vertebral body generally lacks a true vertebral body that vestigial odontoid process is attached to C2, which allows rotation about that axis. And then it is held together rather than by a pure ligamentous construct, which we'll see lower down in the spine, by very strong ligaments as labeled here. So if you guys can see my cursor, we have the apical, alar, and transverse ligaments. There's an extension of the posterior longitudinal ligament as well that extends up through into the clivus. The subaxial spine. This is a fancy term for everything below C2. So as you saw in the previous slide, the C2's nickname is the axis. So everything below that is the subaxial spine. The osteology here is still very unique, but also very redundant. It becomes much more reliable. The unique features of the subaxial spine in comparison to other regions of the spine are going to be the foramen that allow for transit of the vertebral artery, the uncinate process, which articulates with the cranial vertebra, in addition to the axial orientation of the facet joints, which generally allows much more freedom of motion than the coronally oriented thoracic facets and the sagittally oriented lumbar facets. The vertebral artery. So while the central nature of the spine generally gives us a lot of large vessels passing through and around it, this is the artery most integrally and anatomically associated with the spine. Now, this is important because this is a salient this is a salient anatomic location in your dissections that you want to know where it's at. You can predict where it's at and avoid it. So the vertebral artery, which is depicted here in this image on the left, is going to travel through the vertebral foramen, usually entering at C6 with some anatomic variations. This is a good representation of a vertebral body where the vertebral foramen would actually transit, or the vertebral artery would transit through the foramen. This is a representation of C7, which has the vestigial structure without enough space for the vertebral artery. So typically C6 and above, we're looking at the vertebral artery being involved. And then finally, there's a unique numbering system to cervical spine nerve roots. We start above C1 in our numbering. Now, to this point, I'm not sure how much exposure all of you guys have had to the spine, but a lot of people have started, talking about disc herniations and such, lumbar radiculopathy, and we're used to talking about numbered nerve roots going underneath the pedicle of the coassigned vertebral body. That's not the case in the cervical spine. But the discordance between the number of cervical vertebral bodies and the number of nerve roots eventually normalizes that to what you're used to by the time we get to the thoracic spine. So as you can see here in this column, we have 7 cervical vertebrae. And we have C1, like I said, is a little odd. It starts above. And then up through C8, every cervical vertebra, cervical nerve root is going to exit above its named cervical vertebral body until C8, which is not associated with a cervical vertebral body, goes below C7, and then everything kind of normalizes to below after that. All right, so now we're going to go through and take a patient history. So what are the first things we want to do? You're in the room with a patient. You have a given amount of time to assess what their complaints are. I would say the first thing you probably would like to do is to rule out any red flags, things that are going to immediately target your examination and plan. So in the cervical spine, these will primarily be asking for symptoms such as hand clumsiness, decreased dexterity, gait instability, urinary retention, non-dermatomal sensory loss or tingling paresthesias, and a non-myotomal weakness, more global weakness. Those are, if they start, and they'll say these in different ways, but if you see or hear them describe one of these things, that really should point you more towards one of the more elevated diagnoses of cervical spine pathology, which would be cervical myelopathy, or more global upper motor neuron compression. Now, I would say that while that does occur in clinic, at least in my practice, which is a bit of a younger population in the military, that's not the vast majority of what I'm seeing. So then we go down to what trying to parse out what their symptoms are and what the hierarchy of the symptoms are. So you start asking, weakness, is there any weakness? Patients will describe this in a myriad of ways, but most reliably, it means that something is harder for them to do than it was, meaning something's heavier, or they can't perform a task as easily, something like that. Numbness is quite self-explanatory, and then the ever-forwarding neck pain, that's also going to come in. If we get down to that point, and the patients generally are presenting with some degree of extremity pain, or extremity symptoms, whether it's radicular pain, paresthesias, neuropathic pain, and they also have neck pain, then you have to start triaging what's bothering them the most. Assuming that there weren't any big red flags, you have to decide what's bothering them the most, and that can target what you want to address with your treatment plan. A great place to start. A lot of the myotomes, or the muscle groups that we're testing, and to a certain degree, even the sensory dermatomes, have some dual innervation. But in order to create a focused assessment of the patient, we do have to generalize a bit. And that's what this nettergram does for us, and a lot of times what we do in the clinic. So C5 to T1 are very readily testable. C5 nerve root can be tested with your deltoid strength. C6 with your biceps and wrist extension, although the biceps is a bit more of a 5-6 hybrid exam. I would typically test wrist extension. Your tricep strength for C7, and interosseous for C8. And the reflexes are as listed here. And then I don't know if you guys can see the right column there, but the sensory examination is kind of as depicted here with the lateral shoulder, the thumb and index finger, middle finger, and then the ulnar aspect of the hand, respectively. Reflexes. So reflexes are tested as per the middle column there. We generally want to know one of two things: is a hyperreflexic, meaning you tap at a given percussive intensity, and the patient has an exaggerated response, or a hard to elicit response. And that can tell us a lot of things, really. Reflexes being hyperreflexic generally tells us that the spinal reflex arc has been somewhat disinhibited, is hyperactive, which could lead us to the thought of a more upper motor neuron compressive pathology, versus if the secondary neurons are compressed, we can consider more of a root level issue, or more distal. Gait. Gait is important. We drive this home with our residents. You have to kind of see these different pathologic gaits in order to really fully appreciate what they mean. But generally speaking, there are four flavors of gaits that I'm looking for. So there's a painful gait, an antalgic gait. I think everybody's seen that after a patient gets injured, or you sore, you've had a hard workout. An antalgic gait is generally someone that's reticent to move. A Trendelenburg gait can be seen in patients with hip pathology, or gluteus weakness, and they kind of lean to that side. A wide-based gait, meaning my feet are wider than my shoulders just to get down the hallway. I need that extra base of stability. That leads us to think more of a upper motor neuron, or myelopathic sign. And then a steppage gait, which will come in more importantly in the lower extremity exam, but that is the fourth flavor of gait exam. So this is somebody that has having a hard time clearing their foot during the swing phase of gait. They have to raise their knee exceptionally high, or they have to swing it around. They're just making up a way basically to clear their foot from the ground so they don't trip and fall. So you want to assess their gait and see if any of those are present. And the special tests are typically looking, as Dr. Jackson demonstrated, we're looking to elicit either a radiculopathy with the Sperling's, or with the Romberg's Hoffman inverted brachioradialis reflex. We're looking to elicit some sign of upper motor neuron dysfunction. With the Hoffman and inverted brachioradialis, again, a disinhibited spinal reflex, indicating upper motor neuron lesion, or with the Romberg's, some posterior column dysfunction and decreased coordination. So it'd be great to have you guys' input on trying to work through this first case. So a 42-year-old male presents with right thumb and radial forearm numbness, paresthesias, if you will, and tingling sensation, and some wrist extension weakness. All right. So that's what the presentation is. That tells us a lot. So now we're going through our red flags and our hierarchy of symptoms. No gait changes, no bowel and bladder changes, dexterity changes. Okay. So we've ruled out a lot of upper motor neuron red flags. Strength is markedly diminished, I would say, with a 3 out of 5 right biceps and wrist extension. So, we heard the story with the bolded line. We're kind of thinking C6. It kind of sounds like C6, and now we're going to prove it to ourselves with our exam, and then we're going to drive it home with some imaging. So 3 out of 5. And I think that this was a big part of Dr. Jackson's videos as well, but grading strength 5 out of 5 being normal, hard to break with resistance, depending on who the patient is that you're testing. 4 out of 5, the patient can move the joint against gravity in some resistance. 3 out of 5, the patient is able to move or elevate the joint with against gravity, not with any added resistance from the examiner. 2 out of 5 means that they're not anti-gravity. They can move it with gravity removed, meaning if I'm going to test anti-gravity with my elbow, I have to lay the patient's arm on the exam table or whatever apparatus you want to use, and see if they can make that move now with gravity removed. And then one being firing of the muscle without appreciable strength or motion. So 3 out of 5, the patient's anti-gravity in those C6 myotomes. Sensation is impaired as the patient reported over the right radial forearm and thumb. Reflexes aren't as affected, and they have a positive Sperling's. Again, that was demonstrated with right rib rotation. Closing down those foramen on the right side is eliciting what their problem is. So we've ruled out a lot of upper motor neuron signs. We have concordance. Now we have something that's agreeing with the patient's story. That triad of diagnosis between their history and their exam, we've kind of crossed off 2 of them. So the last thing is going to be their imaging. So we start with X-rays. Generally speaking, we want to look for, spondylosis. That's the term. It's coming up again. So arthrosis of the spine, both in the facet joints and the disc joints. We're going to look for alignment. So this patient has a nice lordotic alignment, or he has a nice lordotic to his alignment to his spine. His spine is also straight when we look straight at it. So not a lot there, but there not being anything there tells us a lot as well. All right. So now we're going to the MRI, a T2 weighted sagittal reconstruction of the patient's cervical spine. And we're looking at, quite frankly, we're looking for something that violates this myelographic effect that the T2 weighted signal gives us. Our eyes see dark versus light. And if we see something pushing into the light, it's easy for us to say, oh, that's not normal, right? Now, it's easy to go to the center and look for the big disc herniation, and we don't see it there, right? But we also ruled out a lot of upper motor neuron issues with our examination. We scroll off to the right of center, and we see this disc herniation here at C5-6. Now, remember, with our cervical nerve root numbering, we're still at the part of the spine where the numbered nerve root is going to exit above its vertebral body. So we would expect this to primarily affect the C6 nerve root as it's exiting. So this is what the axial shows. And I think unless you look at these a lot, this can look like a lot of gray. So I kind of drew what is the disc here with this blue oval, and then the disc herniation with the red. I'll go back through that again. So look at it as it stands with the normal axial reconstruction, disc herniation. All right. So now we're looking at a right C6, C5-6 disc herniation, likely affecting the C6 nerve root. I found this nettergram that looked pretty cool. I think it correlated with this MRI cut pretty well. So it kind of makes a depiction of what we're looking at there. So now, what do we do about it? Well, we won't spend a lot of time talking about treatment. It's a little bit out of the scope of this course, but I think it's cool. So we generally want to remove the offending lesion. So in order to do that most effectively, especially in my patients, I believe this patient was a pilot that wanted to return to an ejection seat aircraft. So I opted to decompress and fuse his spine so that he would remain within regulations to do that. So we did a single level discectomy, partial uncinatectomy. We removed the uncinnates a bit so that I could get out in the foramen and remove the full disc herniation. So now what you're looking at here is the patient's spine. This is, it's my orientation here is likely the cranial vertebra, caudal vertebra. There are pins that distract it. The PLL has been removed, and I have a nerve hook out the foramen. I put a spacer in there, an allograft spacer and a plate. And those are what the x-rays look like. I think he's doing well. All right. Now, let's go to another cervical spine case. 74-year-old female who presents with progressive gait imbalance and decreased dexterity. So right from the beginning, she's already started checking off red flags. We talked about our cervical spine exam. So it's not like Monopoly where we don't pass go, but we still need to do the rest of those things. But we still have a higher suspicion for spinal cord compression now, given my red flags are already going up with this lady. So let's go through her exam, her history and exam. So she can no longer ambulate without a walker. So that tells me that her balance is compromised. She can't walk without a gait aid. And these are the terms that they'll use. They're not going to tell you, well, my dexterity is decreased. They're going to tell you, I can't do this task with small items anymore. In this case, she couldn't button her blouse anymore. And she has progressive urinary retention. She has a full bladder that is hard for her to void. All of these are things that we talked about in that red flag section of the history. Strength. So no longer are these symptoms myotomal or dermatomal. They're just global and hard to localize. And when something's hard to localize and you can correlate it with your exam and they're reporting the same thing, sometimes you should probably believe it, because that just means a lot of neurons are being compressed at the same time. So that's what she was reporting. Sensation, generally symmetric, non-focal. That you can take with that will from the anatomy of the cervical spine. She's hyperreflexic, um, meaning it probably a disinhibited spinal arc, reflex arc. And then she has some positive long track signs. Absolutely. And we've fulfilled, again, the triad of diagnoses, history, examination, and imaging, at least for an orthopedic surgeon. Um, we've fulfilled two of these already for a patient that's progressively myelopathic, likely with some degree of central stenosis. So let's see what the imaging shows. So very significant
Ooh.
spondylosis, I would say,
Ooh.
throughout the subaxial spine. The patient's neck is generally lordotic, not a lot of coronal plane deformity. So there's some utility in that information, but there's a lot of arthritis in this neck. All right, so here's what we see on the MRI. Again, we're looking for that myelographic effect. We should see some CSF in front of and behind the spinal cord, generally speaking, everywhere throughout the spine. I mean, there are some times when patients have a narrower canal than we would like, but generally there should be a stripe there. And this intrusion, if you will, into that stripe effaces and obliterates that. That's your first sign. This dark stripe here is, in fact, the spinal cord, and the color of it changes. Even it just looks like it's swollen, if you will, and that's exactly what's going on there. It's compressed at many levels, many levels. So let's look at this level. This is C3-4. You can see that the cord is effaced. That term means manipulated. The cord has been, the morphology of it has been changed by some mass effect. It's occurring at 3-4, more so at 4-5, and the worst of it's at 5-6. So that would be spinal stenosis with spinal cord effacement and associated cord signal change is how I would probably dictate that. All right. I don't have an operative photo, but I opted for a wide laminectomy and infusion in this older lady for many reasons. But, we talk about the course of myelopathy. She stabilized, and sometimes that's the best we can hope for. So she did not go back to walking or living independently. She was quite frustrated by that. But the fact that she stabilized and she can still get around with a walker is, I'll call that a win in these sorts of cases. Let's see. So lumbar spine anatomy, we're going to push through this in the spine exam, and I want to get to the lumbar spine cases. So generally speaking, there are three regions of the lumbar spine canal. There's the central region, kind of with this little orange pentagon here. There's the lateral recess or the subarticular region. These are the joints. These are the articulating processes, superior articulating processes to be specific. And that is the lateral recess. That'll become, the importance of that will become relevant here in a moment. And then the foraminal region of the canal. So three regions: central, lateral recess, foraminal, at least for the purposes of this talk. Causes of stenosis can be, there's a myriad. There's a disc that's usually here sitting on top of this bone. The disc can be generally bulging due to loss of height. All that tissue kind of bulges out circumferentially and can take up space in the canal. There can be a bit of herniated disc material that can take up space focally in the canal. There can be osteophytes off of the superior articulating process that can start taking up some space. And then also, we have to consider the craniocaudal dimension up and down. So that was all in the axial plane. Now let's consider the fact that the foramen is an oval that's formed by one vertebral body on the top and another on the bottom. These are two separate anatomic structures that are held in an alignment by a disc that's deteriorating that can do all kinds of things. So now we're getting stenosis just from that degree of height loss. And also the redundancy, this yellow ligament, which looks, or ligamentum flavum, which looks quite taut and smooth on this nettergram will start to become somewhat redundant and infolded, hypertrophic, however you want to describe it, and that can cause stenosis as well. So there's a myriad of reasons that you can have stenosis in the lumbar spine. The key is being able to, again, localize more central global stenosis and compression versus a single root level issue. Now, you also have to note that there's no spinal cord down here. The spinal cord is likely terminated up around L1. So all those things we were talking about in the cervical spine, myelopathy, upper motor neuron compression, are not likely going to be present. So with that stated, now we're past C8. So now all of the nerve roots are exiting below their numbered pedicle, but they're taking the scenic route to go out of their nerve tunnel, their numbered nerve tunnel. So let's, for an example, look at the L5 nerve root, purple here. So it is going to exit down here below the L5 pedicle, but you can see it leaves the thecal sac up here around L4. So it takes its path past the L4-5 disc to leave the L5 foramen, which you need to note that because a disc herniation can actually affect the nerve root that is not technically at that numbered level. So hierarchy of symptoms, we're going to rule out red flags, and we're going to determine the hierarchy of symptoms. So red flags in the lumbar spine, again, this is all kind of secondary neurons, there's not any spinal cord down here. So bilateral leg pain, this is kind of non-dermatomal, non-myotomal, global symptoms that are affecting both legs. That's really what are going to affect, and we're going to consider our red flags here. Bilateral leg pain, saddle anesthesia, and again, bladder dysfunction can also be present. Weakness, numbness, and back pain can also be present. We need to know the percentage of back pain versus extremity pain as well. So we're going to go through the same thing, the strength exam that Dr. that Dr. Jackson went through is also going to be relevant. So the psoas or hip flexors will be a nice test for L2. And again, we simplify this for the sake of correlating with radiographic data, because as demonstrated below, a lot of these myotomes are dual innervated. The quadriceps for knee extension will be L3 for the context of this talk. L4 will be the tibialis anterior and knee and dorsiflexion of the ankle. 5 will be the EHL and dorsiflexion of the great toe. S1 will be plantar flexion of the foot. Now of the ankle. So one thing I would like to say is that it's very hard to test a lot of these muscles in the lower extremity because they are large muscles, and specifically with the quadriceps and the gastroc, it's hard to break them. So in order to elicit and to correlate weakness, as will be described by the patient, sometimes you have to do a more functional examination. So for S1, for example, I will actually have the patient go up and do calf raises so that it's more of a functional exam, and it'll allow me to see in real life if they're presenting with any weakness. The sensory dermatomes are as listed here. All right, so let's talk about the lumbar spine case 1. So 34-year-old female who's presenting with left foot, left leg pain, and a left foot is slapping the ground. It's when she steps, she slaps the ground, okay, while walking. Call that a foot drop. So what that's telling us is that when she is trying to engage and initiate her stance phase of her gait, she cannot gradually lower the forefoot down. It just drops. That means it's something that is supposed to facilitate that is weak, typically the anterior musculature. So let's go through the rest of the examination. So she has a steppage gait, meaning she's having a hard time clearing the ground with her foot. So she has to exaggerate the height of her gait, but otherwise normal bowel or bladder function. 2 out of 5 left ankle dorsiflexion. That's marked weakness. Otherwise non-focal. impaired sensation over the first dorsal web space. So we're thinking kind of 5, maybe 4. This is dual innervation. Globally, symmetric reflexes and a positive straight leg raise. So I don't know that this examination is going to allow us to tailor it down to a few nerve roots, definitely on the left side, because it's not global. And, with the dorsiflexion of the ankle and the first dorsal web space, we're somewhere between a 4 and a 5 root as the cause. So we go to the imaging. We see that the patient doesn't have a lot of coronal plane deformity. There's no translation of the vertebral bodies on the lateral images, but there is some degree of early spondylosis. The MRI, the T2-weighted sagittal reconstruction, does show, again, the myelographic effect shows something's intruding into the white of the CSF, and that's likely where the pathology is at the L4-5 level. So this is a normal level. Let's talk about the regions of the lumbar spine, the central region. This is normal. They're lying down during this MRI, so all these nerve roots should be gravity dependent and falling towards the back of the dura. These are the traversing nerve roots. See, there's a lot of fat and CSF around all of them. Everything's happy at this level. Then we go to this level, and again, if you don't look at these every day, it can be hard to notice what's going on. So this is the disc. This is the disc herniation, disc herniation, and these are the nerve roots. So remember, at the happy level, these were kind of right in the subarticular region with everything underneath it. The left side, the traversing L5 nerve root is being compressed. So that's what we're dealing with there. All right, and then another nettergram that kind of correlates with what we were seeing. So, all right. So how do we treat this? So again, this is a patient that's lying with their head to the left, feet to the right. We've made a window in the lamina that allows us access to the traversing nerve root and the disc herniation that's kind of pushing on it. So here's a patient that I treated. So traversing nerve root, the common thecal sac, and if we retract it, we can see kind of the herniated disc material. So that's kind of what we're looking at there. All right. This is our last main case here. So 57-year-old male presents with decreased walking tolerance and bilateral lower extremity numbness and heaviness. So decreased walking tolerance and lower extremity numbness and heaviness. Numbness, generally patients can tell you if their legs are numb. They will not tell you if their legs are weak reliably, depending on the savviness of the patient. Usually, again, it's something is harder to do than it was previously. And at least in my experience, in the lower extremities, that's a common way they'll describe weakness is heaviness. And it's with ambulation, meaning they stand up and this occurs. They sit down, it gets better, or it's not as prominent. So we go into the examination. The legs feel heavy when they walk greater than a block. But we look at the strength. This is a seated examination sitting in front of me. The strength is 5 out of 5 when they're seated. That's very different from what they're talking about. And this is what Dr. Mango was referring to. So now the examination is going to more or less look very normal, but they have this markedly positive history. So you have to somehow work through that difference. So the seated examination, sensory examination, again, without focal deficits, you stand them up, they start to get some of the numbness and tingling. Reflexes are diminished. That can happen in older people. That can happen in peripheral neuropathy, but it can also happen with compression of secondary neurons. No special tests. So generally, lordotic, lateral, lumbar spine on the lateral, marked facet arthrosis, and no coronal plane deformity, but again, a lot of arthrosis is noted on the AP. We're going to expect that this is likely a more global phenomenon since the whole leg is, both legs are going numb, tingling, and getting weak and heavy when the patient stands up. And that's what we see here on this T2-weighted sagittal reconstruction. So we see compression at 3 levels primarily in the lumbar spine. So at L2-3, remember what the happy level looked like on that young patient. I don't think there's a happy level on this patient. I think they're all kind of beat up. So just try to remember that from the last patient we looked at. But the lateral recess is quite tight. The nerve roots look less bunched. They're not as happy. Down here, you can see the lateral recesses are even tighter. And there's also some central stenosis and foraminal stenosis. And then this is probably the worst level here, that you can barely see any CSF between the nerve roots. Now you have this ligamentum redundancy, you have this broad-based disc bulges resulting in what I would call tricompartmental stenosis. So the central and both lateral recesses are involved. L5, S1 is not quite as bad. So what do we do here? In a stable spine without a slip, we can consider just decompressing it. And that's what's done here. I generally do just laminectomies, but one of my reviewers for this presentation was able to send me his lamina sparing technique, which was pretty cool because it correlates with this nettergram. So this is what Dr. Eldafri was able to show me. So generally speaking, you want to, at the disc level where this patient's pathology was, you see here, all of his pathology is at the disc level. You're going to decompress at those levels and allow the nerve roots to breathe right there, and by decompressing all of those compartments. Okay. All right. So just a few slides here at the end, just because sometimes, as we talked about on our examination, we talk about the percentage back or neck pain component. And a lot of times you'll see patients that just, quite frankly, they'll say, yeah, I got this lower extremity numbness and tingling, but I also have back pain. All right. What's the percentage? Put it into two buckets. What's the percentage? That's 80% back pain, and I could care less about the leg symptoms. I say, okay, well, a lot of times there's not a lot that you can do about that. You can try some less invasive techniques or injections with pain management, but sometimes there are some things that we can counsel the patients on. So let's talk about what we can look for. This is a very common complaint. So the examination, the location of the pain. Is the pain central? Is it right in the middle of the back or neck? Is it off to the side in the paraspinal musculature, like a spasm? Is it over the sacroiliac joints? What are the positions? So is it worse if I lean the patient forward or if I lean the patient back? And then finally, is it worse when you transition phases? So if you're lying to sitting, that hurts. But if I stabilize myself, I'm okay. Sitting to standing, that hurts. But if I stabilize myself, it's okay. Those are all important distinctions, and I'll show you why. At least in my mind, I think they are. So low back pain. This is a patient that has come to my clinic, active duty, young active duty female, who's miserable, has back pain, some lower extremity pain, but that percentage that she quoted to me was by far back pain. I was like, I don't necessarily know that we should push for surgery initially. I'm allowed to be very conservative in my practice in the military. She's otherwise was non-focal with her exam, but she did show this slip here on the lateral. So you see that L5 is translated forward with respect to S1. Okay. Now, what I would also like for you to know is that there is a lucency here at the pars intra-articularis of L5, where the superior process tries to connect with the inferior process that's allowing the slip. And one little extra piece of data is if we lie the patient supine, look what happens. It almost completely reduces. So this is what this young lady was going through every time she stood up or sat. This was quite mobile. It's just shifting back and forward. And we went through this for a very long time. And then we decided that we would try to stabilize it. It was a mobile grade 2 spondy, and she did fantastic. She loved it. She was very happy with this result. Facet joints are synovial, kind of zygopophyseal joints, just like all over your body. You have these sorts of synovial joints. They become arthritic and painful, just like your knee or your hip. So what do we do about that? There's, at least in my hands, I would refer this to pain management almost 100% of the time, because at least the group here has a lot of reasonable solutions that the patients do well with. The spinal motion unit deteriorates, which includes the disc and the facet joints in the back. That's painful. And then there's a known sensory anatomy that we can treat. And I'll get into that on the next slide. But what I do want you to know, this is another fine point, because unless you look at the spine all day, you don't know what an arthritic spine looks like. So look at this patient's young spine. Look how clear and clean these facet articulations are. That is what a non-spondylotic spine looks like on the left side. And then look at the patient on the right. You can barely tell where one joint stops and the next one begins. So there's a lot of arthritis in that spine. Each of these joints has a sensory nerve that innervates the joint capsule. Its general purpose in life is to tell you that you have an arthritic facet joint. Um, doesn't provide much proprioception or motor function. So what if we block it or ablate it? That might help, and that's something that's a reasonable solution for these patients. And then finally, if it's over the sacroiliac joint and you see some changes, you have to consider that pathology as well. I'm not too big on sacroiliac joint fusion, but I do have a close relationship um, uh, in our practice with some pain docs that have some an affinity for this diagnosis and can help patients.